All right, let's talk about something every medical student and resident knows all too well: getting exam questions wrong. But what if we could flip that around? Today, we're going to turn those common mistakes into your single biggest advantage for absolutely crushing the boards. Seriously, think about this for a second. What if every wrong answer you've ever picked wasn't a failure, but a clue? What if your mistakes were actually a gold mine, showing you exactly where to focus to boost your score? That's exactly what we're going to do. For the next few minutes, you and we're becoming diagnostic detectives. We're going to dust for prints on these tricky questions and learn how to turn those common pitfalls into actual points. Let's dive in. Okay, let's open up our first case file. We're calling this one High Stakes Pitfalls. These are the questions where a single mistake isn't just about losing a point on a test. It's about a situation where a wrong move in the real world could be incredibly costly. The pressure's definitely on here. All right, detective, here's your first case. A patient comes in with back pain. Seems straightforward, right? But hold on, the plot thickens. They also have weakness that's moving up their legs, and their reflexes are decreased. So what's the classic trap the exam writer is laying for you? The trap is to get tunnel vision on that back pain and immediately order an MRI of the spine. But you'd be completely on the wrong track. The real key, the insight that gets you the point, is that specific combo: ascending weakness plus hyperreflexia. That pattern absolutely screams Guillain-Barré syndrome. Your next thought shouldn't be imaging. It should be a lumbar puncture to analyze the CSF. Okay, next case. And this one's a big deal in oncology. You got a patient with a breast that's gotten swollen, tender, and red fast. You see that classic pas d'orange or orange peel skin. You're thinking inflammatory breast cancer. So what is the one absolutely critical, must-do-now diagnostic step? The pitfall here is any kind of hesitation. You don't wait, you don't just order a mammogram and call it a day. The key insight is that this cancer is incredibly aggressive and it demands an immediate core needle biopsy. That is the only way to get a definitive diagnosis and the staging info you need to start treatment ASA. This is a true medical emergency. Let's shift gears to cardiology. You get an ECG showing stable atrial fibrillation. The question asks for the best initial medication. Now, you have to think like the test writer. What are they really asking here? Are they just testing if you know how to control the heart rate, or is there a much bigger, more urgent priority? And here's the trap: jumping straight to a rate control drug like amiodarone. It seems logical, but it misses the main point. The key insight is that the single biggest, most devastating risk in AFib is a stroke. So anticoagulation is the #1 priority. The right answer is to start something like rivaroxaban to prevent a clot from forming. Always think stroke prevention first. All right, let's close that file and open up our second one: spotting subtle clues. This section is all about those tricky cases with lookalike diseases, the ones that are designed to trip you up if you aren't paying super close attention to the details. So here's the setup. A patient undergoes a CT scan with contrast, and wouldn't you know it, they develop an acute kidney injury. The question is going to hinge on one tiny detail from their urine sediment. What's the specific clue in there that's going to nail the diagnosis for you? The trap is mixing up two really common causes of AKI in this setting: contrast-induced nephropathy and allergic interstitial nephritis. The key is in the urine. If it's the contrast eye, you're looking at acute tubular necrosis, or ATN, and the dead giveaway is going to be muddy brown casts in the urine. But if you see eosinophils in that urine, your investigation needs to pivot hard towards AIN, which is more of an allergic reaction. That subtle clue changes everything. Now, this next case is one of the toughest you'll face, both on an exam and in real life. A baby is brought in with multiple fractures. Your job is to figure out how to distinguish between a genetic condition like osteogenesis imperfecta and the awful possibility of non-accidental trauma, child abuse. This is where the real detective work comes in. For osteogenesis imperfecta, you're looking for clues like a family history of easy fractures or classic physical findings like blue sclera. For child abuse, though, the red flags are very different. You're looking for an inconsistent story from the parents, specific fracture patterns like spiral fractures that just don't happen accidentally in an infant, and other signs of neglect. The history must match the injury. Okay, time for our final case file, the management maze. This is where you've totally nailed the diagnosis, but the question is about the sequence of what you do next. Getting the diagnosis is only half the battle. Picking the wrong next step is such an easy way to lose points. Here's a super common rheumatology scenario.
You have a patient with chronic gout, and it's time to start them on allopurinol for long-term control. But there's a major catch. What is the one thing you absolutely have to do before they take that first pill, or you risk making things much, much worse? It is all about the sequence. If you start allopurinol during an acute flare, you're going to mobilize all those uric acid crystals and trigger an even worse flare. So, step 1, make sure any active flare is completely under control. Step 2, you have to bridge them with an anti-inflammatory like colchicine or an NSAID for a couple of weeks. And only then, for step 3, can you safely start a low dose of allopurinol. The order is everything.
All right, last case, and we're in the emergency zone. A patient's blood pressure is plummeting right after you placed a central line. It's a tension pneumothorax. You know this is bad. What is the immediate life-saving thing you do right now? The key here is speed and not getting distracted. The pitfall is to think about the definitive treatment, the chest tube, first. Nope. Don't do it. The immediate life-saving step is a needle decompression. You stick a large bore needle in the second intercostal space right at the midclavicular line. That releases the pressure instantly. The chest tube comes after, as step 2. You can't delay decompression for anything. So we've cracked a few tough cases, but how do we take these specific lessons and build a strategy that works for any question you might face? Let's put together your official Diagnostic Detectives Toolkit. Here's your blueprint. First, focus on high-yield systems like cardiology and neurology. That's where you get the most bang for your buck. Second, you have to understand the why, the pathophysiology, not just memorize buzzwords. Third, and this is the whole point of today, you have to analyze your wrong answers. Look for patterns in your mistakes. And finally, a classic for a reason, always eliminate the choices that are obviously wrong first. It dramatically increases your odds. And that's a wrap. The big takeaway here isn't to be afraid of mistakes. It's to see them as clues. So I'll leave you with this question. Which one of these traps we talked about today will you be on the lookout for the next time you sit down to do some practice questions? Give it some thought. Good luck out there.